We will next be joined for our second talk of the day regarding the 2020 revision of the Essential Public Health Services Centering Equity. And I'm very grateful to have Jay here to present on these updates to the 10 Essentials of Public Health. And for a little introduction to Jay and his amazing work, he's a wonderful person. He is the Director of Programs at Umoja Behavioral Health PC in Albuquerque, New Mexico, where he continues to utilize his extensive background in public health, community development, and organizational excellence by participating in several community and regional activities. He previously consulted with the U.S. Department of Health and Human Services in the Office of Minority Health and Resource Center. There, he focused on assisting underfunded and underserved communities and organizations. For the last 2 decades, his professional services in the public health field have included assisting his clients improve healthcare access and treatment services to at-risk populations. He is considered to be an expert trainer and facilitator in organizational infrastructure and resource development strategies and techniques. So we are very grateful to have Jay here to teach us and expand our knowledge. And his bio is as well in the chat. And during his talk, if you have any questions, please put them in the chat. We're going to do another breakout at the end of his session. Thank you.
Wow. Thank you so much, Laurel. Could I ask to get my screen share credentials so I can share my screen? Or do you guys want to?
You can share away. I think you should be available to me.
There it is. Let me make sure that I've got the right screen up. Perfection. And if you could just let me know if this is popping up correctly.
It is working.
Oh, all right. Perfect. Well, wow. And I thank you very much for that introduction. Let's see. I guess folks are saying, okay, what's happening today? Who is he? What's this next part? Well, we are here to talk about the 10 essential public health services. These are recently updated last year. And as Laurel shared, my name is Jay Blackwell. I'm with Umoja Behavioral Health. And I guess it's about time that I share a little bit about what we're going to cover today. But before we do that, I think it's important to go ahead and say hello, let you know who I am. I've been working in public health for approximately 25 years. If you say anything more than that, people get all funny. I'm pretty much self-taught in understanding what public health can be. And when I say that, I mean, it was like, growing up in the community, in our community, you were active. I grew up in the South. We grew up in a church community, and what we call advocacy today, what we call public health today, it was work. You just had to do it. It was things that you did to make sure that our community was safe. So starting from then until now, I've had a chance to work with a lot of people, agencies. I've been blessed to be invited into many communities, and I've had a chance to really see what public health has meant along the way. And I'm truly honored to be here in New Mexico right now and to be able to share some of what I've learned. Now, to the right of the screen, you're going to see the infographic that we're really here to talk about today. What you see with this circle, these are the essential public health services. And as Laurel mentioned, now it's a little bit different. We're going to talk about how they've been developed and used. But this time today and for the next few years, we are centering and focusing on equity. So some of the reasons that I'm actually happy to share this information with you. One is like I say, I was pretty much self-taught. So a lot of what actually happens in public health, when you don't go to get your MPH, you have to learn through work, through your colleagues. You have to learn from what you're able to just absorb. And what I love is that these essential public health services, there are actually lots of free resources. I'll be able to share the link with you a little bit later in a few slides, but just if you put essential public health services in your search engine, you'll come up with some really great information. This is a national framework within that the US is now starting to share. It was originally developed in 1994 by a federal work group. And last year and the year before, they started doing some updates. As part of this historical information, they'll really be able to share and describe a lot of the activities that took place. But they really want you to kind of organize your thoughts. Public health is like as you know, this very general term. We had a great first part of the meeting today talking about behavioral health with the ACEs. And the ACEs has actually part of this involved with public health, but there are this essential public health services, the EPHS. It's created around 3 core functions in public health. And there are actually, I think, about 10 of them. So there are still 7 more that can be operationalized. And I'm sure CDPC is going to make sure that happens. But the 3 core functions in public health that the EPHS works with around assessment, policy development, and assurance. The EPHS, and I'm trying to wrap that acronym around my tongue, historically includes both governmental and non-governmental partners when discussing public health, because public health is systemic, public health is holistic. One agency or one entity cannot claim all of public health. We are integrated. And public health systems need now, and another reason to present this is so that we can consider how we can benefit in New Mexico a little bit better from these public health services, because this is a framework that is now being taught throughout the country. So of course we have to define public health and what that means here in the state. So the APHA, the American Public Health Association, says that public health promotes and protects the health of people and the communities where they live, work, learn, and play. The CDC Foundation, which is very much guiding public health discussions in this country. And the foundation helps to make sure that these are implemented throughout the country. It says that public health is the science of protecting and improving the health of people and their communities. This work is achieved by promoting healthy lifestyles, researching disease and injury prevention, detecting, preventing, and responding to infectious diseases. And that overall, public health is concerned with protecting the health of entire populations. These populations can be as small as a local neighborhood or as big as an entire country or region of the world. Thing about it is that no matter how large or how small, we're still talking about people. And when we really talk about public health, for me, public health was more about outreach and prevention. I thought that it was really just about getting the word out. As time come along, I found out that there's this thing called behavioral health, mental health. Is that right? That's part of public health? Well, okay. Well, what about working with our seniors? What about working with our youth? And what about things like research? So when I'm going in there and learning, I'm supposed to be knowing that's public health or just a job. Well, public health reaches all types of populations and communities. And of course, we have to be aware of the role that public health is playing with the COVID pandemic. And of course, we cannot really talk about public health without big data. A lot of public health decisions are now being driven by data. So even with this definition of public health, that's just a definition of like who's involved. How about the organizations that are now going to be impacted by these essential public health services? So I really wanted to start out by looking at public health in 3 dimensions. There is the dimensions of the government, which is HHS, and HHS, Health and Human Services, is actually the 2nd largest budget in the federal government. The first the largest budget is the Department of Defense. So, after, after our protective areas, public health comes next. And public health is kind of broken up into three primary areas that you have here. You have your prevention activities, agencies, regulatory agencies. You have your clinical, your research, and administrative. The logos of the HHS agencies that popped up are some that are quite familiar to New Mexico, quite familiar to most people when they think about what is public health. Well, these are some of the funders. These are the agencies, entities, and the people behind them that kind of set the rules to say what's going to happen throughout the country. But public health also has another face. Public health has the face of communities, it has the face of tribes and specific populations. This is an example of, this is from Washington State, the Yellowhawk Health Center had set up a strategic plan, which ever since I've seen it, I have loved it. I thought it just communicates so much about how the health center wants to operate throughout the tribe, with the community, and to get people to understand this is what we mean by public health. They were able to share that public health has a mission, it has a vision, and it has values, and that everyone that's in the health center wants to respond to healthcare using some of these mission, vision, and value statements. They also were able to identify priorities and strategies about how to implement them in community. This, to me, is a perfect example of public health at the state and local level. Now let's look at public health at the regional level. And who do we have, or who did I select at the regional level? But CDPC. One of the Dr. I don't think it was, I'm not sure what her last name is, but the doctor was talking about sustaining programs in the community. If we're in public health, sometimes we have to do things that are novel. And when we do, we have to get them paid for. And part of public health is also learning how to get your ideas covered, paid for, so that they can continue to be offered to our communities. This is the CDPC Sustainability and Funding Work Group. I would highly advise you to contact Trish Garduno if you're interested in participating. I'm picking on Trish today, although there are several people available in CDPC I can turn to, thanks to Devana, Sophie, and Laurel, of course. But in the sustainability work group, when it comes to how public health looks like in your jurisdiction, come meet some friends, colleagues that we can have meaningful discussion. We can talk about how to increase our professional skills to apply for grants and funding, talk about securing resources. We're even right now considering about how we can share resources in a mutual grant. So CDPC offers an opportunity to implement public health activities, and it is more than just about staying in an office. You can actually join via Zoom, because we do that as well. But let me go on. I didn't mean to transfer too much time. So these essential public health services. Now, when they were revised, and they will be happy to share that a lot of the revisions took place as an opportunity of the pandemic. Folks were at home, and professionals have been using this. I think it was already on their minds when it happened. But after discussions with several professionals, colleagues across the nation, the revisions are really being centered around these 6 themes. Public health, we are looking at it being equity driven, which means that when you think about health for the most impacted, if you improve health for the most impacted, everybody up the chain gets to benefit and prosper. So equity driven means that we look at inequities in areas such as poverty, racism, gender, other forms of oppression. Looking at public health services that are transparent. Transparency is important, especially when folks are not trusting vaccines. Folks are not trusting medical information. Some of our communities find it distrustful of like people that come in to provide services. So transparency helps to break up some of the distrust seen in public health for many communities. Speaking of communities, public health, and this revision had to focus on it being inclusive, engaging our public, engaging our practitioners, including researchers, educators, fundings, and policymakers. A lot of non-traditional players are being asked to participate at our table so we can sit at theirs. An example is transportation. The impact of transportation to access to healthcare is real when as public health professionals, we're able to sit and invite non-traditional partners into our little worlds, we get to see a better view of how health can be impacted by bringing more of our community in. It is also data informed, evidence driven, futuristic, something that we have learned working with other communities. We need to look more than just right now, just at the present, because a lot of times healthcare happens along a continuum. It may start with what happened in our grand era and continue what happens into our future area, our children's area. And the public health revisions had to be relevant. I don't want to spend a lot of time because, like I said, this information is readily available. Here's the link. It is found through cdc.gov. And then there are the rest of the pieces, or you can just type in essential health services into your search engine. And a lot of this information can be shared with you as well. You know, what we really just want to make sure that we all understand is that, you know, this is doing more than just going to the job and coming back. I think most people in public health are in it because of the vision and with the possibilities of how we can make the world a better place. But sometimes we need to see how we fit together as opposed to always having to be the star. Let's move on. When it talks about this development of how these revised standards came along, the first circle, the initial data collection and analysis, it really gives you the whole picture. Initially, it started around the spring of 2019, and then they went on for about 18 months until December of 2020, when these new standards were really begun to be shared throughout the country. So as part of the revision process, there was the data collection part, which happened first in the spring, about a year or so, draft revisions, then there was some vetting that was going on. Is all of this stuff true and correct? Of course, there was the data analysis and the framework development, and then the framework launch. To again receive the specifics, check out, this is what you would look for in your search engine. The title is de Beaumont. They were the entity, the Beaumont Foundation is the entity that kind of convened bringing these communities together. They conducted the environmental scan. They brought together the task force of the subject matter experts. And you can read, went through all of that. I just want to point out that, you know, it took 18 months. This is something that was pretty well researched. And it was built from experience, not just books. Books are definitely important, but what we have learned is that when it really comes to providing services well, let's remember to really focus on our communities as well. Let's see. Trying to move on to the next thing here. Right, go here. I'll go here. So this is what the whole hullabaloo is about. The 10 essential public health services. You're going to become very familiar with this infographic through the years. What you're going to see is that the infographic keeps you moving. Public health services is definitely an activity. You're going to see that there are 3 major areas, which are assessment, policy development, and assurance. And right in the middle is equity, 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 equity. So there was even a lot of time spent on this sentence under the heading, to protect and promote the health of all people in all communities. And then we have the write-up. The 10 essential public health services provide a framework for public health to protect and promote the health of all people in all communities. To achieve equity, the EPHS actively promote policies, systems, and overall community conditions that enable optimal health for all and seek to remove systemic and structural barriers that have resulted in health inequities. Barriers include poverty, racism, gender discrimination, ableism, and other forms of oppression. And let me say, it took a long time for me to actually hear oppression in the halls of the federal government. I was told to shush one time, and it has stuck in my mind. Of course, I didn't. So I'm really happy to see it here today. And everyone should have a fair and just opportunity to achieve optimal health and well-being. So we've had a chance to talk about public health. We've had a chance to look at this infographic. Now let's go on and talk about what is equity. And the definition that I have up here as an assumption, this is not perfect. It was never meant to be perfect. It was never meant to be complete. It's not a beginning or an end. It is what I am suggesting, that we look at this framework of equity, this the 10 essential public health services as a framework, and how in our work in New Mexico, we can see where we have strengths, and we can also see where we can maybe do some things different or try some new things. So equity. So what is equity? Let's introduce equity as a framework for public health professionals to figure out how we can protect and promote the health of all people in our communities, jurisdictions, and purview. Moving on, let's take a look at these public health, essential public health services. What I'd like to describe, you'll see for the next 10 slides, including this one, you're going to see the essential public health and how it fits under one of the 3 areas. We're starting with assessment. Then you're going to see that there is the definition: assess and monitor population health status and factors that influence health and community needs and assets. And then I have highlighted in the yellow some of the approaches, some of the strategies that are important in working in this particular area. And what you're probably going to find is that many of you are already doing many of these strategies. What is exciting is when we can get together with our colleagues and be able to have an informed decision and talk about how we are utilizing them, what we're seeing, and how we're working with our communities. Okay, so number 1, assess and monitor population health. Some of the operationalized approaches include maintaining an ongoing understanding of health in the jurisdiction. Of course, that's collecting, monitoring, and analyzing data, looking at patterns, threats, emerging issues. Using this data and information that we have to determine root causes in health disparities and inequities, working with the community. Again, when we talk about centering our work in equity, then we have to talk about engaging communities and communities. It's just so many, so we can better understand the health status, needs, assets, key influences, and narrative. We have to do some collaboration. One agency on its own is unable to address complete public health care. Even the government alone cannot properly do health care. We need community partnerships. Using innovative technologies, various methods to interpret the data that we collect. And then this bullet, I love this bullet so much, using disaggregated data. For instance, in the last presentation with the ACEs, At the time, we were unable to see how ACEs scores for Black communities, uh, um, API communities, our Pacific Islander communities, any of the LGBT communities, they weren't disaggregated. So we get a partial picture of what that looks like. We have to just trust that all modalities are going to work with the major. And we know that that's not right. Using disaggregated data is a practice that we must continue to demand when it comes to working with our communities better. Engaging community members as experts and key partners. You don't have to have an MA, a BA, you don't have to have a lot of the degrees in order to be informed and in order to be able to share what's best or what's working or what's happening in the community. Let's move on to number 2. Investigate, diagnose, and address health problems. Some of the key words including anticipating through epidemiologic identification, identifying patterns to develop strategies that address chronic diseases and injuries, using real-time data, using public health laboratory capabilities and modern technologies to conduct rapid screening and high-volume testing that flows directly to what we are experiencing around the world today with the COVID pandemic. Analyzing and utilizing inputs from multiple sectors, and identifying, analyzing, and distributing information from new, big, and real-time data sources. Big data and data collection activities are becoming more and more important, especially when we begin to inform our leaders about what we think is happening versus what we know is happening. Let's continue to move on. And again, even though I realize I'm moving a little bit quickly, please know that all of these are available on the web. And also CDPC does have a health equity work group. I think Dr. Ryan Warner is leading it, and they'll be happy to kind of follow through with a lot of other activities. But number 3 is communicate effectively to inform and educate people about health factors, the health factors and how they are influenced and how to improve it. So some of the approaches are developing and disseminating accessible health information and resources through collaboration with multi-sector partners, ensuring we all get the same information at the same time. Using appropriate social media channels, social media, peer-to-peer networks, mass media, other channels. Deploying culturally and linguistically appropriate and relevant communications and educational resources. Since I've been in New Mexico, I've often seen the struggle about what it means to share information to communities and what you think a community wants to see, how they can get it based off of sometimes national data versus actually what a community is going to use, accept, and be guided by. Without, this culturally and linguistically appropriate approach, a lot of contractors put out information that is often harmful, and that often that the providers who are part of that community have to then go back and correct the messages and the messaging. So please, again, make sure that what we're doing is not in vain. This goes to build trust with communities and populations. It goes directly to that. When communities know that we would prefer to work with you rather than do work for you or at you, it makes a difference, and it takes time. And ensuring that public health communications and education efforts are asset-based, strength-based, when appropriate, and do not reinforce narratives that are damaging to disproportionately affected populations. And I could go on and on about that, but that is not why I am here. Let's go on to number 4. Make sure I can keep on track. Number 4, strengthen, support, and mobilize communities and partnerships. So now we are into the policy development phase. Convening, facilitating multi-sector partnerships, such as what we are engaging in right now. Building genuine, strength-based relationships with a diverse group of partners. I'm reminded of the saying, if you always do what you've always done, you'll always get what you've always got. We need to do a little bit differently now. Let's be focused on equity. Authentically engaging with community members. And sometimes as professionals, we don't want to hear what they have to say. And sometimes as professionals, it is completely appropriate to listen. And as we listen, we can learn from, support existing community partnerships, and contributing public health expertise. We are here to work together. Let's go on to number 5. Create, champion, and implement policies, plans, and laws that impact health. So this slide, as I've kind of outlined already, some of the actionable things are championing policies, plans, and laws, improving existing policies and plans, ensuring that these policies and plans provide a fair and just opportunity for all to achieve optimal health. Things like access, things like making sure I can, of course, think back to rural access to vaccines. And in rural access to vaccine, how did the minority populations, how were we ensured that they got access? And we did here. We did an awesome job here, looking at the data to validate what we think we know versus what we're actually able to demonstrate. So developing policies, plans, and laws. And then the last bullet, working across partners and with the community to systematically and continuously develop and implement health improvement strategies and plans, and evaluate and improve those plans. It's so wonderful to have a plan on the books. We really do need to make sure that it's current, up to date, actionable, and paid for. A lot of people have plans that they can't implement because they didn't create a budget alongside of it and a way to then make sure that those budgets, policy, plans, ideas can be put into practice. Let me keep on with what I'm talking about. Number 6, utilize legal and regulatory actions, regulatory laws. Who likes to be regulated? But we all are. Applicable, this services includes ensuring that applicable laws are equitably applied to protect the public's health. When we look at enforcement activities, sanitary codes in the food industry, drinking water is safe, timely follow-up on hazards, preventable injuries, exposure-related diseases identified in occupational and community settings. Our scientists should not be allowed to run off into rooms and communities and then just stick there and throw reports to us. Our scientists need to be invited to our tables so that we can hear from them firsthand some of the impacts, some of the things that they are seeing, and how these work together in a intersectional way to impact, improve, or to the detriment of our health. Regulatory activities include licensing and monitoring. Many of the colleagues that are on this call have been licensed, thank goodness, and credentialed, thank goodness, saying that you are where you are because you've gone through a process that systematically prepares you to work with the people in your field. So reviewing new drug, biologic, medical device applications is part of public health. Licensing, credentialing, and including health considerations and laws from other sectors. Let's go on to number 7. A lot of these really sound like what you're already doing because you already are. The only thing that's different, we weren't always taught to put this into an overview framework to show how we can work better, but also be focused in what we do. And the suggestion that we're trying to really bring home is that this discussion around equity and the frameworks that impact equity are important within our professional field and will be for at least 10 to 15 years. Essential public health service number 7. This is about ensuring equitable access. How are our programs connected to populations throughout the state? How do we ensure access to high quality and cost-effective healthcare and social services throughout the state? How are we addressing and removing barriers to care throughout the state? Maybe you found a great way to do that within your neighborhood or within your community. And what we need to hear now is how can we do that or replicate that throughout the state? And we do that by building relationships with payers, healthcare providers, including the sharing of information across partners to foster health and well-being. That's number 7. Let's look at number 8. I want to make sure to give you guys some time. It's not just about me yammering here. Number 8 is to build and support a diverse and skilled public health workforce. By this, we mean providing education and training that encompasses a spectrum of public health competencies, including technical, strategic, and leadership skills, ensuring that the public health workforce is the appropriate size to meet the public's needs. Now, there's this thing called the health professional shortage. I think there's another acronym, another letter up in there, but New Mexico does not have an appropriate health workforce to meet the needs of the people. Many states are under threat about meeting the healthcare needs of the populations that we are tasked to support. So this is definitely one of those major activities that needs some discussion. It needs some innovation. It needs some creativity. And we need some different ways to figure out how to bring in our communities. A beautiful way, example is the CPSW, the Certified Peer Support Worker. CPSWs can be that linkage in the chain to really improve not only access to healthcare, but then health outcomes. CPSWs are able to work at a lower professional standard, still credentialed, still trained, still professional, but what they're able to provide, it's like if there's a fire, a CPSW can come in and put out the fire. And then a therapist, for instance, can say, wow, now that that fire is out, let's talk about how you got there, what that situation looked like. It's about how we work together in our field, building a culturally competent public health workforce and leadership that reflects the community and practices cultural humility. Again, not so much about the degrees, which are important and we do need and want. It's also about how to be inclusive. So we can incorporate public health principles in non-public health curricula. We can continue to build active partnerships with academia. So important. So happy to see you, Dr. Taylor, and other professional training programs in schools to assure community relevant learning experiences exist for all the learners. And again, fostering that leadership skills at all levels. Going to continue on, number 9, ongoing evaluation and research. Oh my Lord, so important. You know, there's this thing called implementation science in public health. And generally, from doing the studies to it becoming the impact and the outcomes and the benefits of the studies, it normally takes about 2 years for the general public to really get the benefit. And even though that's the norm, it doesn't have to be that way. Before I go and talk about this, I guess you guys can kind of read that. I want to talk about the Vanderbilt Institute for Clinical and Translational Research. Their acronym is VICTOR, V-I-C-T-R. VICTOR has free, F-R-E-E, tools and examples that have been created for researchers and community organizations that are conducting research to use and share their study findings in everyday, easy to understand language. So I'm sure many of the folks that are on here are familiar with this acronym CBPR, community-based participatory research. Community-based participatory research is a way that researchers can demonstrate and validate the awesome programs, ideas, initiatives that a lot of communities are experiencing and CBOs and health centers are implementing. This Victor, the Vanderbilt Institute for Clinical and Translational Research, VICTR, can assist, again, researchers and our CBOs to really share this wonderful stuff that you're doing. This is helping us address number 9, which is ongoing evaluation and research. This is talking about when it comes to research, how are we fostering a culture of quality in public health organizations and activities? How do we link public health research with public health practice? Huge, most of you know what I'm talking about. And using research to inform decision making. It is evidence, practice-based insights, and other forms of information. This research and these things that are happening on the sidewalk in the field are contributing to the evidence base of effective public health practices throughout the country. And they use engagement and decision-making structures to make our jobs much better. This is just really hot. It's just really a wonderful place to be. And we really want to encourage professionals here to engage in some research, check it out, and see how we can partner with to improve what we do. Number 10, build and maintain a strong organizational infrastructure for public health. This is the tricky one. Why? I think you'll see where I'm headed to. This includes developing an understanding of the broader organizational infrastructures and roles that support the entire public health system in a jurisdiction. Government agencies, elected officials, NGOs, which are non-governmental organizations, ensuring that appropriate needed resources are allocated equitably, exhibiting effective and ethical leadership, decision-making, and governance, managing financial and human resources effectively, strategic planning capacities and skills, having robust information technology services that are current and meet privacy and security standards. You can't help but see how folks' information is being ransomed virtually a lot. And being accountable. You can be accountable in 3 ways. You can be accountable with the money, you can be accountable to your clients, and you can be accountable to your staff. So being accountable, transparent, and inclusive with all the partners and the community in all aspects of practice. So these are the updated 10 essential public health services. And of course, there's information you'll be able to find them. Whenever we think about these, we always want to start at home. And we always say, well, like, what is our starting place? My starting place is always with the data. And what does the data say? What does the data reflect? And from the data, how am I able to reconcile that with what I'm seeing in community, with what I'm hearing from my colleagues and peers? And where is information missing and where is it right? So these are just places to stay. So of course we have the New Mexico Community Health Status Indicators. There's a link here. This is through IBIS. This is what we are all supposed to be at least referring to. And again, this is on a statewide basis. And of course, I'm a big fan of CDPC. I guess that's why they asked me to talk, because one of the other things that they have, as I mentioned before, is the CDPC Health Equity Work Group. When it comes to how these essential public health services are operating in a factual way, in an actual way throughout the state, how are we actually or functionally addressing health disparities? What are we doing to correct them? How are we sharing information? What data do we have? these are kind of things that you should really like ask Dr. Warner to take on. Until then, just like I said, I'm picking on Trish Gardunia today, and Trish's email is in this slide as well, and then she'll be able to connect you and make sure that you can participate at whatever level you are comfortable with. And this is exactly what I think the onus is about. Everybody here decided to say, okay, I should probably know these 10 essential public health standards. Now what? Now what? Are we doing things correctly? Are we doing things in a way that can be improved? Are there any opportunities? What might be next? What could be next? And what role do I want to play in this process? And that's a very individual thing. But more than anything, I definitely want to thank you for your participation. My name is Jay. I work at Umoja Wellness here in Albuquerque. I think that's pretty much all that I really had for my presentation today, because this is really more of an introduction. It's not an end point, but a starting point. So at this point, whoops, I can just figure out how to do this. I think I just put that back over to CDPC. At least I hope that's what I did. Was that successful, John? I don't know.
We'll find out in just a moment, I think.
Okay.
I think we
Okay.
will. Good. I think it's
Okay.
going to work. Thanks, Jay. I wanted to open up folks to answer any questions for Jay. Ask any questions you have of him and regarding to the 10 essentials of public health services. And I also wanted to share with folks some questions that we want people to consider as well as we get into a breakout conversation. Jay, I just wanted to ask you, I know that, when I looked at these and as you're sharing them, and I hadn't really looked at these very closely before, I realized in 2014, they didn't really have the lens of health equity, which these are looked at. And I think they've been better, they've been upgraded now in a way that's more, I think, relevant to communities and to people with that health equity lens. You mentioned in these different public health services, these essentials, that one of the things that I didn't notice that wasn't there that I felt could be incorporated, or maybe it's just understood, is that what's not there is sustainability, funding, and resources. I recognize that certainly that partnerships and collaboration is a way to expand and utilize existing resources and not duplicate them. But I'm wondering what you might say in response to, like, you being also a person who is chairing this task force around sustainability and funding. How would you respond to that, and how does that, what would you say to maybe us to start to look at that deeper?
Oh, I am all the way, really the whole funding portion for me is about priorities and about how we have an opportunity to put our money where our mouth is, so to speak, when we start looking at how we do want to fund priorities and really look at them. You're correct. In the 10 essentials, they really didn't address it head on. And that is like always something that I've found curious. How can this be a priority if it doesn't have a budget associated with it? What makes it a priority? The fact that you're able to say that it's a report, or is it a priority because we are emphasizing change? So I can only point out that I'm just in agreement with you. We can take it back to the Beaumont Foundation and see what they can say about that as well.
I want people to know too, if they're interested in participating in that sustainability and funding work group that has been developed, that this kind of subcommittee that's there, that looking at how we can address chronic diseases and how people might collaborate and not just collaborate, but also learn about how to apply for these kind of resources is part of that subcommittee that you're chairing. And I just wanted to invite people to let people know, if you're interested, to connect with Jay or Laurel, if you're interested in joining in on that group and learning more about, grant writing and funding yourself, but maybe applying for resources together. So with that, I want to share the screen for the breakouts. Laurel, I know we've got getting those set up. Is that right?
That is right. I have the breakouts ready to go. So this is round 2, and
I
Devonna.
got the questions up here, Laurel, for folks. It's just after exploring the revised 10 essential public health services with this better lens on it, what might you do differently to center health equity in your work? The other question to explore is, how do you believe New Mexico communities might benefit from utilizing the approaches discussed in Jay's presentation? Also thinking about what collaboration or training opportunities would you like to see initiated to support these essential public health services in New Mexico? And what impacts would you expect to see if in New Mexico communities, if these health essential health services were implemented more consistently in your particular field? So with these, I think as last time, based on our time, and Jay, I'm open to you if you want to elaborate on any of these or encourage people to look specifically at any of these as well. But
certainly, John. One of the things I really want to point out is that, these essential public health services, they are already things that we're doing. That most of these things we already, as professionals across the state, are really trying to do anyway. It's just that it's nice to see that sometimes we can go a little bit deeper or look at another application. Especially sometimes hoping, one thing that I'm seeing less here than I've seen in other places across the country is, how do your outcomes move the healthcare needle? And what did you mean to move? Like for instance, how did your activities get more people vaccinated? How did your activities pass out more condoms? And who cares if they did? Did they impact a number? Did they, change the healthcare status after 5 years? And again, really trying to encourage, this is why we want to work with our researchers whenever we can as well, so that, one, it's great to be published. I have seen so many novel, beautiful interventions in New Mexico. I just wish we could share more. I'm talking too much now, John. Sorry.
No, it's totally fine. It's clear that you're passionate about it, and that's what's going to move the needle, I think. So thanks for elaborating on these. So I wanted to ask Laurel, I think you've got to set up for some breakouts to look at these questions, and if there's anyone that you want to dive deeper into as a breakout group, certainly encourage the health equity dialogue wherever we can as part of one of our priorities for our shared strategic plan around addressing health equity in the state. So with that, Laurel, do you want to set us up? And I just in case anyone needs them, I did put the questions in the chat.